Hello, I'm Matt Davids from Dana-Farber Cancer Institute in Boston.
Hi, and I'm Bill Wierda from MD Anderson Cancer Center in Houston, Texas.
All right, and Bill, we're going to be talking today about abstract 68, which was frontline treatment with I plus V, ibrutinib plus venetoclax, the 2-year post-randomization disease-free survival results from the phase 2 Captivate study. So just by way of a little bit of background, we've known for a while about this combination of ibrutinib plus venetoclax, going back to some of the preclinical work done by your group and our group, and then the great data that you generated at MD Anderson in your single center study. And then we've seen a little bit of data from Captivate previously, you've presented and others, and we've seen published data as well. So maybe start by telling us kind of what this study is all about, and then we'll get into some of the results.
Sure. So the Captivate study was initiated several years ago. It is an all-oral targeted therapy combining ibrutinib with venetoclax. The initial design of the study was to evaluate for undetectable MRD status at the end of 12 cycles of combined therapy, and those patients who were confirmed undetectable would be randomized to placebo versus continued ibrutinib single agent, and those who were not confirmed as undetectable with regard to MRD would be randomized to ibrutinib monotherapy versus continued combined therapy. Now, there were 164 patients enrolled in that initial, what's referred to as the MRD cohort, and the primary endpoint for the Captivate study was to look at the 1-year disease-free survival for the cohort of patients who had confirmed undetectable MRD status and were randomized to either placebo or continued ibrutinib single agent. The study was modified subsequently, and so there was a fixed duration cohort added. That fixed duration cohort patients received the 12 cycles of combined therapy, and then all the patients stopped treatment at the end of the 12 cycles of combined therapy. And there were 159 patients enrolled in that fixed duration cohort. But the primary endpoint for the Captivate study, which is, as I'm sure you understand, a phase 2 trial, was the 1-year disease-free survival for the confirmed undetectable MRD cohort and comparing placebo versus continued ibrutinib single agent for those patients who had been confirmed. Now, the confirmed as undetectable MRD. Last year, we reported the 1-year disease-free survivals, the primary endpoint. This year at ASH in abstract 68, Paulo Guia updated the data and reported the 2-year disease-free survival. Now, the 1-year disease-free survival is consistent with the 2-year follow-up. In fact, there were actually no additional events of disease progression as defined by the protocol between year 1 and year 2 follow-up. And the overall conclusion is that patients who achieved a confirmed undetectable MRD state could discontinue treatment with similar expectations in terms of disease-free survival based on the fact that there was no difference in 1-year disease-free or 2-year disease-free survival between patients who were assigned to placebo versus continued ibrutinib single agent. That's the primary endpoint. Now, there are a number of additional secondary endpoints that have been reported on this study and have been updated at the ASH this past December. One of which was progression-free survival. So the progression-free survival is no different actually between the confirmed and unconfirmed undetectable MRD cohorts, regardless of what treatment they were assigned to, realizing that other than the placebo cohort, all the other groups of patients continued on treatment, whether that's ibrutinib monotherapy or continued combined therapy. The other endpoint that was important and updated by Paulo Guia was improvement in undetectable MRD state, particularly for those patients who were not confirmed as undetectable at the end of the 12 cycles of combined therapy, in looking at improvement in undetectable MRD status between those patients who were assigned to ibrutinib monotherapy versus continued combined therapy. And essentially, the continued combined therapy resulted in a higher portion of patients achieving an undetectable undetectable MRD state. I think this is important because it shows the potential for continued therapy achieving deeper remissions for those patients who don't achieve undetectable MRD at the end of the finite duration that was agreed upon in this study of 12 cycles of combined therapy. I think the work that we need to do now moving forward is to develop clinical trials that have MRD as the endpoint and can clarify and identify the appropriate or optimal duration of treatment with combined therapy in order to achieve good undetectable MRD outcomes for our patients. And then finally, the safety data from this trial is important, both from last year's update and this year's update, in that there were no significant safety issues with combined therapy. It was well tolerated. And in fact, these patients all received 3 cycles of ibrutinib monotherapy prior to their combined therapy. And that was successful in reducing the proportion of patients with a high risk for TLS down to medium or low risk. So it was very low numbers of patients with high risk for TLS by the end of the 3 cycles of ibrutinib monotherapy as a debulking strategy. The other issue was that for patients who came off treatment, either by virtue of receiving placebo or being in the fixed duration cohort, there were 12 patients who had progression and were restarted on treatment with ibrutinib. And thus far, 9 of those patients who were evaluable for response have responded to treatment as a partial response to reinitiation of ibrutinib monotherapy. So there's data that's being generated on this trial, also in longer follow-up, with regard to retreatment with ibrutinib or reinitiation of ibrutinib for patients who progress.
It's certainly a robust data set, and thank you for that fantastic summary of the data. I think sort of one final question I would have is that we're expecting to see probably a label for I+V coming at some point, maybe this year. So what patient population are you thinking about using that in?
Well, it's all oral therapy. It's ibrutinib plus venetoclax. I like the concept today of avoiding a CD20 antibody because of the immune suppression that we see with the CD20 antibody and relevant to the current COVID state and these surges that we are experiencing. So that sort of the current setting, clinical setting and COVID situation makes me think about it a little more proactively because of the avoidance of the CD20 antibody. I'm interested in looking for data that clearly demonstrates improved outcomes with this combination over venetoclax plus obinutuzumab. I'm thinking about this combination for patients who are who have an unmutated immunoglobulin gene, patients who are younger, and again, I'm looking for data that supports, and we'll see that in a randomized trial, which is being done right now, this German CLL study group, CLL 17 trial. So I do anticipate that it will be approved, and I think with the follow-up and the MRD, time to MRD relapse and those comparative data across trials will help identify what patients most benefit from this combination.
Well, thank you very much, Dr. Wierda. I always learn from you, so great to hear your perspectives on the Captivate study update. And thank you all very much for your attention.
Thank you.